SAMINA, TARIQ, Assistant Professor, Pediatrics, Unit 3, Dow Medical College. And today's lecture is about hypoxic ischemic encephalopathy. So it is colloquially known as birth asphyxia, or it's also called perinatal asphyxia. So more vogue is hypoxic ischemic encephalopathy. So it's characterized by clinical and laboratory evidence of acute or subacute brain injury due to asphyxia. And what do you mean by asphyxia? It means hypoxia, lack of oxygen due to respiratory causes like choking. Traditionally, it's said that, but in case of fetus at the time of delivery, it can be due to hypoxia caused by any cause. We'll come to the different causes in a bit. Systemic hypoxemia or reduced cerebral blood flow can cause the symptoms of HIE. So the question is, why are we talking about this today? It's always. So I hope you can listen to me.
जी मैम हेलो
इसमें एक मैसेज आ रहा था कि कैन यू सी कि स्टूडेंट्स को आवाज जा रही है?
बशीर आवाज आ रही है बिल्कुल। ये बंद कर, ये वीडियो खोलिए।
भले बंद कर दो। मैंने इसको अनम्यूट किया था। टेक्निकली एडवांस कंट्रीज मैसेज आ रहा था, जा रही ना? ठीक है। There are like 1 to 4 cases per 1,000 live births. But overall, if you see the global incidence is like 23% of all neonatal deaths worldwide. That's a lot. That's a big chunk. It's 4 neonatal deaths. So it is one of the top 20 leading causes of burden of the disease in all age groups. In terms of disability, and World Health Organization is the 5th largest cause of death of children younger than 5 years, which is 8% of deaths. So whatever data that we have, it is estimated that 9,20,000 neonatal deaths occur every year. And it is associated with another 1.1 million intrapartum stillbirths, which is again because of hypoxia. And the children that are exposed to this kind of trauma, 1 million children who survive birth asphyxia develop problems such as cerebral palsy, mental retardation, and they become a burden on the system. Okay, so what's the pathophysiology behind it? Brain hypoxia and ischemia due to systemic hypoxemia reduces cerebral blood flow. Another primary physiological process that leads to hypoxic ischemic encephalopathy. The initial compensatory adjustments to an asphyxial event, an increase in CBF, that is cerebral blood flow due to hypoxia and hypercapnia. This is accompanied by redistribution of cardiac output. Now, whatever the important organs are, like the brain and the heart and the adrenals, they get more blood supply. And blood pressure increase with increased release of epinephrine further enhances this compensatory response. So there is a autoregulatory phenomena in the brain of all the humans, which is known as cerebrovascular pressure autoregulation. It's a physiological mechanism. The thought behind it is that the cerebral blood flow is kept to be constant across changes in cerebral perfusion pressure, which is directly related to the arterial blood pressure. So in adults, whenever blood pressure increases, the autoregulatory mechanism causes the flow to maintain over a wide range of blood pressure changes. And this mechanism is also there in cases of fetus at the time of delivery, and that helps a bit, but it is not as well managed as in adults. And autoregulator may be impaired due to various neonatal diseases, including HIE, intraventricular hemorrhage, congenital heart disease, infants on ECMO. And because infants are explicitly sensitive to changes in cerebral blood flow, both hypoperfusion and hypoperfusion can cause significant neurologic injury. In adults, this serves a very good purpose because the skull is a closed space and the brain, which occupies 80% of the volume of the skull, and the other 20% occupied by blood and CSF. So we have to maintain the caliber of the vessels and the amount of CSF that is formed. In neonates and infants, because the skull is open, so that also helps in maintaining the intracranial components at an optimum level. So this is the graph that tells us what happens with cerebral blood flow when the arterial pressure increases. So you can see that there's a plateau in the middle, saying that the cerebral blood flow remains relatively constant over a wide range of arterial blood pressure changes. This is cerebral blood flow autoregulation. So the mechanism is a myogenic mechanism. You must be remembering from physiology, the Starling's forces are there whenever there is stretch on the vessel wall. It's the Poisson's law, I think. Where there's stretch on the vessel wall, it causes the myogenic fibers in the media tunica media to contract, and that then regulates the blood flow. So this I already talked about. But if the BP falls, CBF falls below critical levels, and the brain injury secondary to diminished blood supply and lack of sufficient oxygen occurs. This leads to intracellular energy failure. Why does intracellular energy failure occur? Because of low oxygen and because of low glucose, less ATP is generated. So there is intracellular energy failure. During the early phases of brain injury, brain temperature drops. Now these are compensatory mechanisms initiated by the fetus, that there is some amount of temperature drop and there's local release of neurotransmitters, inhibitory neurotransmitters such as GABA, which is increased. These changes reduce cerebral oxygen demand. So nature tries to minimize the devastating effects of asphyxia by these two mechanisms and by the autoregulation mechanism. But when the system becomes overwhelmed because asphyxia becomes severe, or if it is prolonged, the length of stay of asphyxia also directly gives us evidence of the neuronal defects that may be produced by it. Now, what causes all the devastation that's there in asphyxia is excitatory amino acids EAA receptor overactivation. There's uptake of glutamate as the major excitatory neurotransmitter, and the results of high synaptic levels of glutamate and EAA receptor overactivation and NMDA increase, AMPA increase. So NMDA receptors are permeable to calcium. They increase the level of calcium, and there is loss of the activity of sodium potassium adenosine triphosphatase, leading to rapid cytotoxic edema and necrotic cell death. And when neuronal cell death occurs, then much can't be done about it. So the quicker we are in our action, the quicker we can tackle hypoxia during the perinatal period, the better the results will be. So as I said, there is whenever there is hypoxia, there is redistribution of blood to heart and the brain and the adrenals, and along with hypoxia, hypercapnia and acidosis also develops if we are not there to help the situation. And if this scenario persists, then cerebral blood flow will eventually decrease and ischemic brain injury will ensue. There is a concept of plasticity in adults these days, which is quite commonly circulated these days. And we, the older people, we feel very much blessed by that concept of plasticity, because it gives us, it says that neurons can be generated and more neuronal synapses can be generated if we have enough cortical activity. But at this stage, if neuronal loss occurs, then there are permanent changes. So, some interesting facts: the infant brain consumes 17% of cardiac output and accounts for 17% of the body mass. In comparison, the adult brain comprises just 2% of the total body mass, but utilizes 25% of the cardiac output. Low placental vascular resistance, low arterial oxygen content of the fetal blood both influence fetal CVF. Afterwards, CVF increases during the later days of life. So what are the actual causes? Now, coming to the clinical scenario, what are the clinical scenarios in which we expect that the newborn might experience HIE? The most important is prolonged labor. So obstetrical management, proper management is very important in this regard. And it accounts, one study says that it accounts for 45.6% of, almost 50% of cases of HIE. Then other causes are obstructed labor, prematurity, poverty, IDR, eclampsia, then meconium aspiration syndrome, precipitate labor, premature rupture of membranes, congenital malformation and retained twins, and some other causes. So proper antenatal care and proper care during the delivery process is of utmost importance to offset the occurrence and the devastating effects of HIE. So in 1996, the American Academy of Pediatrics, and in collaboration with the American College of Obstetrics and Gynecology, they devised a definition for HIE, and they said all of 4 conditions should be there. Some amount should be there in some way in order to enable the fetus to be suffering from HIE. So profound metabolic or mixed acidemia with a pH of less than 7 in the umbilical artery, and persistence of Apgar score of less than 3 for longer than 5 minutes. Neonatal neurological sequelae in any form. It can be coma, seizures, hypertonia, multiple organ involvements like the kidneys, lungs, liver, heart, and the intestine. Necrotic changes occur in these also. So all of these in some form of the other, they define what HIE is. So there are different categories of HIE. Like I said, the duration of HIE is important for the ultimate outcome of the child, as well as the severity of HIE is important. So they have divided HIE after very long observations on newborns into mild, moderate, and severe categories, and the different things that are considered in this classification are the level of consciousness. In mild, the child is hyper alert. In moderate, the child may be lethargic, and in severe, stupor and coma. So if the child is has an altered level of consciousness, this is a very ominous sign. So nowadays, if you look at newborns, they just open up their eyes and they are so much interested in the surroundings, and they stare at everything, especially the mother. So they are quite alert. So if the child is alert or hyper alert, then also we should be aware that it might be HIE. Then we have to look for other signs and symptoms. Spontaneous activity, normal spontaneous activity, the child is moving his limbs normally. If then that might be normal or mild HIE. And if it is decreased, then it will be moderate. And if there is no activity, the child is just lying there without having any movement, then it is severe. And then tone, if the tone is normal, the child might be having mild HIE. If mild hypotonia is there, then moderate. And if the child is totally flaccid, lying there, it will be severe. Posture. So if there is some amount of flexion, normally the child would move his limbs. So if there's some amount of distal flexion is still there, it might be mild HIE, strong distal flexion, then moderate, and decerebrate posturing, in which the limbs are hyperextended and inverted, then it might be severe HIE. Now, mind you, this has to be taken into consideration as to what happened during the perinatal period, during the antenatal period, and during the delivery. If there were risk factors and they are combined with these symptomatology in the neonate, then we label the different grades of HIE. Stretch reflexes, if they are overactive, then it might be mild or moderate, or if they are absent, it can be severe. And myoclonus, if it is present, it may be normal, mild, or moderate, or if they are absent, it can be severe. Then the different neonatal reflexes, suck, Moro, and oculovestibular reflexes, if they are if the suck is weak, or if the suck is weak or absent, or if the suck is absent, that would grade the HIE into mild, moderate, and severe. Moros normally is quite strong in cases of normal or mild HIE, and it can be weak and moderate, and it may be absent and severe. Oculovestibular can be normal and mild, overactive and moderate, and absent and severe. Autonomic system, pupils, if the pupils are dilated, it can be mild. If they're constricted, it can be moderate. And if they are in a middle position and they're non-reactive, then it can be severe HIE. Heart rate, initially, like in all cases of shock, tachycardia occurs initially, but later on it leads to bradycardia, and then in severe it can be variable. Usually brady is there. Respiratory may be normal and mild, and maybe periodic and moderate, and they may be apnea and severe. Secretions may be sparse, moderate may be profuse, and severe can be variable. Seizures, excuse me. So usually seizures are not seen in cases of mild, they're common, and in severe also they are common, but later on if the severe goes unchecked, then the seizures may not be visible. And EEG may show mild depression in cases of mild HIE, moderate depression in moderate, and severe depression in cases of severe HIE. So this is just a repetition of what I just said. So mild hypoxic ischemic encephalopathy, muscle tone. Usually you can see that what the normal findings are in the child, and it progressively goes worse. You can see that the CNS becomes less and less active as the hypoxia becomes more severe and more prolonged. So muscle tone may be slightly increased, dependent reflex may be increased during the first few days. Transient behavioral abnormalities such as poor feeding, irritability, excessive crying, or sleep or excessive sleepiness may be observed. And if at this stage, when there's mild hypoxic ischemic encephalopathy, if we are able to control it, especially it is said that if this whole scenario doesn't go beyond 6 hours, then the recovery is rapid and the recovery is good, and the long-term consequences are less. And it typically resolves in 24 hours. Moderate hypoxic ischemic encephalopathy, infant becomes, now you can see that he's become more lethargic because of the energy failure, significant hypotonia and diminished descending reflexes. All the neonatal reflexes start becoming sluggish, and occasional periods of apnea may be there. Seizures typically occur within first 24 hours after birth. It may occur during moderate hypoxia also. And if the child is in this stage, you catch him in this stage, and if you do appropriate therapy, then there may be full recovery in 1 to 2 weeks. and it is associated with better long-term outcome. But if the child is in severe hypoxic ischemic encephalopathy, and if we are not proactive in controlling this thing, that seizure, then there can be devastating effects on the child, long-term devastation. A disabled child in one family is devastating, not only for the child, but particularly for the family and also for the society as well, because they become a burden on the society. So it is of utmost importance that we are very vigilant in this kind of a scenario. Seizures can occur, they can be delayed, and they can be severe. As injury progresses, seizures subside, and the electroencephalographic becomes electroencephalographically becomes isoelectric, and or they may show burst suppression pattern. Wakefulness may deteriorate further, and the fontanelle may bulge, suggesting increasing cerebral edema, increasing ICP. Then the other symptoms, stupor, coma can occur in severe HIE. Breathing becomes irregular or apneic, generalized hypertonia. As I said, neural reflexes are diminished. Disturbance of ocular motion, such as skewed deviation of the eyes, nystagmus, bobbing movements, loss of doll's eye movement, which will tell us that the brainstem is not becoming involved. Cranial nerve abnormalities may be seen. Pupils may be dilated, fixed, or poorly reactive to light. Irregularities of heart rate, blood pressure are common. When the brainstem starts becoming affected, then the vital functions become affected. As initial period of well-being of mild hypoxic encephalopathy may be followed by sudden deterioration suggesting ongoing brain cell dysfunction, injury, and death. During this period, seizure intensity may increase. So it is a continuous process of deterioration as HIE progresses. So I said you have to see the risk factors, and you have to see the findings in the neonate, and then if we think that the child is an HIE, then other laboratory findings will help us in diagnosis, like serum electrolyte level, renal function, because hypoxia is affecting all the organs in the body. So it's affecting the kidneys. So you might have rising creatinine, and electrolyte levels may be deranked, potassium may start rising, cardiac enzymes may start rising, showing that there is hypoxic damage to the cardiac muscle fibers, and liver enzymes may be increased, showing that hepatocytes are becoming affected. Coagulation system may be deranked, which prothrombin time may be increased, APTT may be increased, fibrinogen levels may get depressed because of the effect on the liver. Arterial blood gas monitoring is used to assess acid-base status and to avoid hyperoxia and hypoxia, as well as hypercapnia and hypocapnia. So we have to have a good monitoring system and a good treatment strategy in order to combat the devastating effects of HIE. So an MRI of the brain can be done later on. Cranial ultrasonography can be done, echocardiogram, EEG. Then later on, to see what kind of neuronal damage has occurred. Hearing test in whenever we are following up cases of CNS insult, like in case of meningitis, entails hearing test. And here also, when the child is labeled as CP, hearing test is done to see how much deafness is there, if it is there in the first place. The retinal ophthalmic examination, all these things help us in management of the child. So initial resuscitation and stabilization is of utmost important. Treatment of HIE is largely supportive and should focus on adequate ventilation, perfusion and blood pressure management. Studies indicate that the mean arterial blood pressure above 35 to 50 mm is necessary to avoid decreased cerebral blood flow. Careful fluid management is there, avoidance of hypoglycemia and hyperglycemia. So whenever we are suspecting HI, we have to maintain all the relevant area properly. Oxygen should be supplied to the child, and we have to see that hyperoxia doesn't occur in that, right? The glycemic control is also very important. We have to see that the glucose level is within normal limits. Usually the child goes into hypoglycemia. So in case of hypoglycemia, glucose needs to be given, and in cases of hyperglycemia, we have to control the amount of glucose that we are giving. It's usually iatrogenic that hyperglycemia occurs. Careful fluid management important. Then we have to see the kidney function. Usually pre-renal azotemia is there because of the ischemic changes, and if we are able to control it during mild and moderate HI, then whatever creatinine increase and electrolyte imbalances are there, they become normal later on. But if the child goes into severe HI, then there is renal azotemia, and that becomes difficult to manage. Sometimes some amount of renal azotemia can also be reversed by a prompt management. The blood pressure needs to be maintained within the optimum level. And as I said, adequate ventilation is important. Now, like I said previously, naturally, the tendency of nature is to reduce the metabolic functions of the brain, and automatically some amount of hypothermia occurs. I do not know exactly how that occurs, but externally, if you can control the temperature of the child, if you can reduce the temperature of the child, and therapeutic hypothermia can be done to like 30 to 33.5 degrees. At this level, if we are able to maintain for like 72 hours, then the chances of recovery of damage becomes very good. And this is followed by slow and controlled rewarming of infants in cases of moderate to severe HI. And avoidance of hyperthermia. Normally what we do is when the child is born, we clean the child and remove all the vernix, and then we try to cover up the child, and we're trying to maintain the temperature of the child, and also the room temperature is maintained at a slightly higher level in cases of birth. But then in this case, when HI is there, we are trying to produce therapeutic hypothermia, and there are many studies have been done world over, and we have found that therapeutic hypothermia maintenance in HI cases has resulted in less neuronal damage in as seen by CNS examination, by the cranial motor system examination, high intellectual function examination. It has been seen that they are better off when therapeutic hypothermia is entertained in cases of moderate to severe HI. So it not only depends upon the grade of HI, but it also depends upon how proactive we are. So it is said that if within 6 hours, if we are able to control the situation and we are able to track the oxygen level and the glucose level and other parameters towards normal side, then the immediate necrotic cell death that is destined to occur in these cases, that would be halted, and cerebral metabolism transiently recovers. So we are actually controlling the sodium overload and the calcium overload, and the nitrous oxide that forms in the brain, we're controlling that. The radicals that are formed, we are controlling that. The excitatory neurotransmitter that accumulated, we are controlling that. And we are controlling sodium, potassium, again, ATPase by all our interventions. After transient recovery of cerebral energy, metabolism, secondary phase of apoptotic neuronal cell death can occur. So if we are able to control all these parameters, the child will have a very good recovery. But if there is more than 6 hours after the start of the insults, then mitochondrial dysfunction occurs, and then the insult becomes permanent. So how do we do hypothermia? There are two ways of doing hypothermia. Either you can just cover the head with a cool cap. Cool cap is a nice terminology. Or you can have full blanket covering the whole body. Usually it is seen that cool caps are much easier to use, and they give as good a result as full body hypothermia. So hypothermia, mild hypothermia, which is 3 to 4 degrees below baseline temperature, applied within a few hours. It's like I said, less than 6 hours gives us very good recovery. It is neuroprotective, and neuroprotective mechanisms are not completely. How does this occur? We do not know. Nature also does this partly. If we can provide this externally, it helps a lot. And scientists, there are lots of schools of thoughts about this. There are lots of things that are in pipeline for the neuroprotective effects to be initiated and trained in the neonate. Possible mechanisms for hypothermia includes reduced metabolic rate and energy depletion. So we're trying to conserve energy by reducing BMR and decrease in the excited neurotransmitters, alteration in the iron flux, reduced apoptosis due to hypoxic ischemic the nasopharyngeal or rectal temperature is then monitored, and it is maintained at 33 to 35 degrees for 72 hours. The other thing is whole body hypothermia. The infant is placed in a commercially available cooling blanket, and through which circulating cold water. The cooling blanket also has like channels of in which the water can flow. So cool water is pumped through the channel. There is a pumping device, and this also the desired level of hypothermia is reached quickly in cases of whole body hypothermia. And whole body hypothermia is widely used to provide therapeutic hypothermia. Rewarming. Now, once you think the child is coming out of HIE and his metabolic parameters, his oxygen and glucose and renal function and liver function and cardiac parameters and brain parameters, EEG, they are all coming back to normal. So then we start rewarming. Rewarming is a critical period. Rewarming is carried out gradually over 6 to 8 hours, in which the water that is pumped into the circulating channels that is gradually rewarmed, and it should take like 6 to 8 hours for it to completely come back to. So this is the cool cap. We tried one of the cool caps a couple of years back in our pediatric ICU also, and we found good initial results with that. Long-term follow-up was unfortunately not there, but people who have done long-term follow-up in these patients with cool caps or cooling blankets, and they have found that as compared to a control cohort of children who had the same kind of therapy, you have not had cool caps, but they were having HIE. The neurological outcome for those was slightly worse than the neonates who had the benefit of cool caps or cooling blankets. So it looks like the child is feeling cold, but this is all better for you. So this is the blanket version of the hypothermia mechanism, in which the whole body of the child is wrapped in a blanket, and the temperature is reduced down to 33 to 35 for 72 hours. And it's not a very big, we can see that it's not a very dramatic intervention, but the results are dramatically good. So this needs to be implemented in our system also. So the other thing that is very important in improving the outcome of these neonates with HI is treat the seizures, and we cannot let the seizures go on and on. And the earlier we control them, and the effectivity with which we control them, that is what most important. So even if the child is not having seizures, then we should do EEG. And when EEG is done in this child, and if there are no seizures clinically or visibly, but there are seizure activity in the EEG, then also we need to give management of anticonvulsants to these neonates. And normally what is used is phenobarbital, phenytoin. These are the regular stuff that we use in our wards to control seizures in case of epilepsy or in cases of meningitis, encephalitis, or metabolic, or whatever the causes. We have to control the actual cause of the seizures, sorry, not in metabolic, but in epilepsies and in the acute phases of meningitis and encephalitis, we use these phenobarbital, phenytoin, lorazepam. The other that are used are midazolam, which is widely used these days for conscious sedation. We use midazolam for during endoscopic procedures when the child doesn't completely lose consciousness, but his sensorium is hampered, and his sensitivity to overactivity and pain is reduced. So levetiracetam is also used. So besides that, cardiovascular support, renal support, that is also important. These agents, which increase in blood pressure and they combat shock, they should be used. These increase the systemic vascular resistance, cardiac contractility, and stroke volume, thus increasing the cardiac output, thus bringing up blood pressure. So whenever there is a dramatic drop in blood pressure, which is definitely going to cause havoc in the brain, so we should use dopamine, dobutamine, which is the standard therapy. Okay, follow-up. Follow-up of these children with HIV is very important, because at that time the mother, the family doesn't realize the implications. We have to have a guarded approach in counseling these parents, and usually when there is mild HIV, the children in future, they do generally do well and do not require specialized follow-up. So there are different protocols in different setups. Normally, during the initial 3 months, we call the child every 15 days initially, then 1 month for 3 months, then for the next 3 months, we can call them in 3 months and then 6 months. And during all this, we not only see the growth parameters, but also we see the developmental parameters of the child. We see how the child is doing. We know that normal maximum growth occurs during the first year of life, and the development is quite dramatic during the first year of life, and we have a full-fledged follow-up system. And we can see what happens in the first few weeks and the first few months, and at 1 year, and at 1.5 years, 2 years. And normally follow-up is taken to 2. And if the child is developmentally delayed, then obviously that is going to fall into the follow-up plan for the CP child. But if the child appears to be normal, so to 2 years, you follow the child, and that's about it. The growth parameters would include head circumference, the weight of the child, the increase in length of the child. During the follow-up period, we have to detect impairments that might help the child. Like if the child is developing hearing loss, then we have to we have to refer the child to the ENT section so that they can help them with devices or whatever mechanisms are there, so that the child doesn't become mute later on. If his hearing is impaired, then his speech will be impaired later on, and that is very serious. That has a very serious effect on productive activity of the child in future. Infants with moderate to severe HI should be followed closely after intensive care discharge by developmental. Okay, so there has to be multidisciplinary approach: developmental pediatrician, pediatric neurologist, and pediatric ophthalmologist, pediatric ENT people, and all of these have to be involved. And later on, physiotherapy department also needs to get involved if there is a threat. And at discharge, we should do a standard screening, hearing screening test, and later on it should be followed up. So it's a long, cumbersome process, so which can be easily prevented by our proactive approach during the HIV occurs. So there are a couple of thoughts which are in the pipeline for the future, and there are a number of neuroprotective strategies that are there in the pipeline. Like I said, hypothermia is already being practiced in different areas, which produces a several metabolic rate, and there are other mechanisms by which hypothermia helps. Then NMDA receptor channels can be blocked by magnesium. There are different clinical trials being done in different hospitals who are using magnesium to combat the effects of HIV. Then decrease glutamate release can be done with adenosine antagonists, adenosine uptake inhibitors, and inhibit voltage-sensitive calcium channels by calcium channel blockers. So these are not easy things to do, especially when you're dealing with neonates. The monitoring system, the follow-up system would be quite extensive. So very well-planned clinical trials are being done to see the effectiveness and the safety. First of all, we have to see if these things are safe to be used in the child. Calcium channel blockers can actually dramatically drop the blood pressure. So during the designing of the clinical trials, we have to consider all of these things. People are doing this. Hopefully, in near future, we'll have lots of new strategies coming up our way, and that will help the children suffering from HIV. It is surprising that a lot of work has been done in providing better obstetrical care to mothers during the antenatal period and during delivery, but the occurrence of CP children has been consistent. So maybe these metabolic problems are there behind these children who ultimately become CP, who suffer from HIV. Maybe these things are going to go a long way in helping these little people. Then reducing free radical reactions by free radical escape ranges, allopurinol, vitamin C, vitamin E, superoxide dismutase, SOD, and to prevent free radical formation by indomethacin, iron chelators, allopurinol, nitric oxide inhibitors, decrease inflammatory response by allopurinol, inflammatory antagonists, blocking interleukin-1 and TNF alpha and steroids can be used. Attenuate apoptosis pathway by caspase inhibitors. These are lots of things that are in the pipeline these days. Clinical trials are being done, and we'll see how it fares out. So thank you very much for your attention, and if you have any questions, I'm here to answer them.
जी डॉक्टर समीना।
जी लेक्चर तो खत्म हो गए. So if they have any questions.
अभी तक तो कोई क्वेश्चन नहीं है.
स्टॉप करेंगे क्या करें? क्वेश्चंस